Okay, thank you everyone for joining us on this fine Wednesday morning. We are really thrilled to have another webinar from the California Telehealth Resource Center, and this one is really well timed and themed. Today, we will be talking about California legislative update, anticipated new Medicare policies for calendar year 2025, as well as federal DEA regulatory updates. As a reminder for all attendees as you are joining, you have been muted and your cameras are off, but that doesn't mean we don't want to hear from you. We are going to encourage you to use your Q&A function and your chat function to post your questions and your comments for our presenters and the CTRC team. We'd love to hear from you throughout the session, and we will be holding space at the end of today's webinar to go through your questions. In addition, we want to let you know that today's session is being recorded, so if you would like to revisit the content or share it with some of your colleagues, we will be sending out the link to the recording by the end of today. As a reminder, CTRC does not provide legal advice and has no relevant financial interest, arrangement, or affiliation with any commercial products or services that may be mentioned in today's session, and our disclaimer is available if you'd like to read it. And just a little background to those of you who may be new to the California Telehealth Resource Center. If you're not familiar with us, CTRC has been around since 2006, long before telehealth and digital modalities were really cool. We offer unbiased, no-cost digital health resources and support services. And that is us, if you'd like to read a little bit more about the CTRC and what we do. And now I will hand it over to our Executive Director, Sylvia Trujillo, to introduce herself and our other presenter. Thank you.
Great. Thank you, Aislinn. I also want to make sure that we are acknowledging Aislinn Taylor, who is the manager of the CTRC program, and herself has been here through 7 years, really helping to advance the work. I'm super delighted to have a national expert join us and is not only a national expert, but holds down two jobs at the same time. Jennifer Stoll is the president of the California Telehealth Network, as well as the Chief External Affairs Officer of OCHIN. We are likely going to have her come back to come and present on all the things that she's learning in the AI space. As you can see here, she is really at the epicenter of much of the policy-making discussion around healthcare AI, chairing two national initiatives, serving on advisory boards. And if that weren't enough, she's also leading work around underserved communities in the cybersecurity arena for the healthcare sector. So we are delighted to have her providing the update on the California Legislative Roundup and the outlook for next year. And then I will follow Jennifer's presentation and provide an update on where we are on the regulatory front with regard to telehealth, remote physiological monitoring, and provide an update on DEA and virtual prescribing. So with that, I would like to move to the next slide and tee this discussion up for Jennifer Stoll.
Thank you, Sylvia, and thank you, Aislinn. And I want to recognize the really, really incredible leadership of the CTRC team with Sylvia Trujillo as the executive director and then Aislinn as the manager. So thank you both. And also, I also want to thank HRSA, who is our funder, as well as our partners in California with HCI and CHCF as really strong sponsors of the work we do. So thank you all. So I was asked today to come here to share a little bit about what happened in the legislative world in California, what was going on in Sacramento, and provide some updates on really looking at the health information technology world, as well as telehealth, of course, and all things digital modalities. California is very active in looking at being a unique place for digital technologies and the regulatory and legislative environments. And so I'm going to share a little bit about what happened during the 2024 legislative session, some key themes that we saw, and review what the governor signed and what he didn't sign. Again, this is by no means a comprehensive list of everything legislative. Yes, you can go to the next slide, Aislinn. Thank you. I just want to make sure it really is with the lens of the digital modality perspective. So just level setting, some of the things that really loomed large over the 2024 general session is the fact that we are in an election year. It was the second year of a biennium. And so many of the bills that didn't make it in 2023 did get carried over into 2024. So that created some noise in the beginning of the session. To be able to have to address some of those legislative pieces. There was one key piece of legislation around building a digital health information exchange framework, and some of the governance structure around that. That ultimately did not make it through the session. But really looking at the general election this year was a big topic, and moving into this fall where a lot of policymakers we're going out to campaign for various other offices. And there is going to be a large new class of members coming in next year. So the legislative body continues to turn over. And I think that's really important because it does loom large in terms of the policies that get advanced in the legislature. And there was obviously a budget shortfall. I think there was nobody didn't know about that this year. The debate was what was the shortfall and whose numbers do you support and believe. But this definitely impacted the whole legislative process, and anything with a significant fiscal impact on the state budget really didn't make it this year. And so we're going to review some of that. And then the last thing that I think is really important is the battle over the managed care organization tax. Many of you know that the MCO tax expires, and we're looking at what a new tax package would be to be able to provide medical services in the state. So those from the healthcare perspective really were looming large this session. You can also see there is a ballot initiative that you will be asked to consider. It is definitely something that you want to dig into and review, and it's Proposition 35. This would again sustain funding, and you can see on this slide there's kind of a side-by-side comparison between the current law, which is really the managed care tax, and what Prop 35 does. So please spend some time getting familiar with this, and I'll spend a little more time on this as well. Aislinn, if you want to go to the next slide, please. All right, so again, some of the policy themes that we saw during the legislative session, here are 5 different buckets, from AI to climate change to housing, and making sure that we are figuring out a way to increase supply, to also how do we help those that are currently unhoused. There were bills passed on criminal justice reform, and then looking at healthcare and consumer protections. We're going to spend a lot of time sitting in the AI space. I think this is an important conversation for California, as California is really leading policies around AI and the regulatory environment in the artificial intelligence space. And Aislinn, I'm not able to see the chat as a side note, so if there are questions, please prompt me. That'd be great. So we're going to go through some of the bills that were introduced, some of the themes that were introduced on AI, as well as those that didn't make it. California, as I said, is really leading the way, given that on a federal side, as much as there is a desire to have a regulatory environment and structure around artificial intelligence, it is still forming, storming, and norming. Especially through the office of the ASTP, the Assistant Secretary of Technology Policy, now also has an office of AI. They announced that a few weeks ago. So if you're not watching that, please make sure you're watching it. but California is ahead of the federal government and as well as a few states. And so making sure that we are also aligned with where the federal government is going so we don't have a fragmented system of AI regulation is something that we've been watching very closely at OCHA. These were general themes. You can also see removing medical debt. This is going to be a larger conversation, especially at a federal level. I think this comes back next year. Looking at, again, building more houses, who can build houses faster, and what does it mean for local government? So there was a large conversation between local jurisdictions and the state, looking at reducing the use of solitary confinement and for vulnerable populations, and again, managing climate. So if we want to go to the next slide, you can also see that the governor signed 800 new laws and rejected a variety of other laws. So, but again, the big looming theme was how much money there was in the coffers this year. The budget impacted healthcare pretty significantly, and the spending plan for the health departments had a decrease of $3.8 billion, 9%. I think this is interesting to really evaluate. It feels very much like feast and famine. We had during the pandemic, there was resources available and opportunities for public health to engage, as well as other health departments to engage. But the pendulum has swung the other direction with these decreases in funding. And a handful of modest augmentations of health programs, but in general, it is a major general fund problem. So we saw a lot of healthcare programs either being deferred to future years for implementation or just being reduced or cut altogether. So I'm sure many of you are impacted by that. You're watching it. We'd love to hear from you what's generally impacting you as it impacts the general budget. But please let us know what you're paying attention to, and we would love to hear more about that. But funding will continue to be a problem also, and it is expected to continue to be a problem into the 2025-26 biennium. So please be aware that we don't feel that this issue is going to go away quite yet. The legislature is going to continue to have to grapple with shortfalls of revenue. And at some point, we anticipate that the legislature and the governor's office are going to have to look at revenue solutions in totality. So it's definitely something that we're keeping an eye on, and that will continue to loom large over the legislative sessions to come. So next slide, Aislinn, please. So let's talk about some of the AI legislation that the governor did sign. There were well over, and Sylvia can correct me, but there were well over 35 to 40 pieces of legislation introduced around artificial intelligence, looking at how do we define it, transparency around AI, and governance structure. And I think what we have seen is that with a lot of the legislative concepts, only a few made it through. Many of them did have a pretty significant fiscal impact on the state, so they did not make it. Thank you, Sylvia. I appreciate that. But there are two major pieces of legislation that will be really setting the course of quite a bit of the country's response around AI and development. One is AB 3030. This requires healthcare entities using generative AI tools to create responses for provider communications that include disclosure. Disclosure is really key, being able to say that there's a human in the loop and that there's an awareness that these were AI responses, and it was done in a responsible way. There were some other bills around training transparency that didn't make it, but AB 3030 did make it and was signed into law. So we wanted to lift that up for you because it will impact both you as a provider, but also being able to look at AI in terms of the development and the implementation of many of these products that we're considering. Um, Many of the definitions bills did not make it through, which is interesting. Oh, sorry, Sylvia, please correct me if I'm wrong, and you can come off mute. Um, there are several definition bills that created broad definition. Sylvia, I see you're off mute. Sorry.
Yeah, that's absolutely correct, Jen. These are the bills that made it through, but there were all total, I was looking at the count here, 50, well over 30. There were 55 AI bills introduced. Only about 38 AI bills made it to the governor's desk, and an even smaller number were actually signed by the governor.
Thank you. Thank you. Yeah, and so the other bill we wanted to point out was on governance. But going back to definitions for a second, I think this is important because there isn't a single standard definition of what artificial intelligence is. There is definitely this drives a lot of questions about policies. And so it'll be something that we'll continue to watch and monitor both from a federal perspective as well as on a state level. And finally, governance. The bill that did make it through was Senate Bill 1120. This creates a utilization review and requirements for health plans and disability insurers that use AI. It must not be used for automatic denial or delay of healthcare services. We will be anxiously watching on how this bill gets implemented and how the agencies that oversee the bill wind up looking and putting this in statute. So yeah, so out of all these bills, there's only a handful that made it through. And these are the three big themes: definitions, transparency, and governance. This world is still the Wild West, everybody. We are still storming, forming, and norming in this space, both on a state level and a federal level. We anticipate this is not the last cluster of AI bills that we will be seeing in the California Assembly. We expect that it will come back again and again and again. And as the market continues to mature, and the Wild West continues to settle down, we're going to see the regulatory environment and the legislative environment also settle down. But right now, it is very, very noisy. And 2025, we can anticipate more of the same. Reading and reviewing a lot of legislation around AI and its impact to healthcare, but also the provider writ large, as well as the patient. If we can go to the next slide. So the governor also vetoed quite a bit of legislation. And unfortunately for the telehealth community, the bill that we were anxiously awaiting was 2339, which expands on Medi-Cal definitions and the use of asynchronous telehealth, which we were disappointed to see. Personally, Assemblywoman Aguiar Curry has been a wonderful telehealth champion to this community, really advocating on behalf of the rural and underserved providers across the state. And this bill did not make it through, predominantly because of the perceived fiscal impact that it has onto the state budget. The other telehealth bill or bill using virtual care that was also held in committee due to potential budget concerns was AB 2726. This would create a pilot program to build integrated on-demand specialty services using virtual technologies. And you can anticipate that bill will come back in 2025. But unfortunately, both of those bills that would continue to have advanced telehealth did not make it through. The other bills that I think are of note that are interesting for this community was AB 2250. This looks at actually incentivizing and paying providers to screen for patient social determinants of health and be able to provide outreach. It would have mandated the health plans to do this. The governor rejected this bill, again, on fiscal note reasons. And then the other bills really are around automation or looking at AI that we wanted to lift up, automated decisions, um, establishing safety and privacy and non-discrimination standards for AI. That's a Senate Bill 892, and then device disclosure, AB 2058, as well as looking at having Senate Bill 1047, which is a Secure and Safe Innovation and Frontier of Artificial Intelligence Models Act, probably one of the more controversial bills that ultimately wound up being rejected by the governor. So, interestingly, several packages of legislation around that did make it through the legislature was rejected. Several of them on digital modalities and telehealth. So, more to come. I don't think this is the last time we're seeing that these bills or these ideas be introduced. Many times it takes multiple bites at the apple to get things through, or several, consensus building. As you know, this is how the sausage is made. So we're really excited to see where it goes moving forward. All right, next slide. Okay, so I touched on this a little bit, and I'm really curious if there are any questions that anybody has. But in terms of the outlook for next year, as I mentioned before, the budget doesn't seem to be healing all that rapidly. And, there is we could be facing more economic slowdown, and then increasing costs for healthcare and infrastructure. These are all things that we are going to be keeping an eye on. I think it's really important to understand, budget really drives a lot of the conversation of what they can do. And then it becomes a large conversation about horse trading with what can be and what should be paid for. So the three themes that we discussed, or the four themes that we discussed earlier around budget. It will also be interesting if Prop 35 passes. The legislature will have to address that as well. So, there's this conversation around funding and healthcare is going to extend, long into next year. It never seems to end. And who is accessing healthcare and who pays for it. I think that's my last slide, Aislinn. And yes, and I'd really love to open it up to any conversation. I know we're asking questions of you in the chat, everyone. And I would love to hear what's on your mind.
I think just to facilitate a little bit here, Jennifer, a couple of questions that I think many providers that we've heard from have asked about is what is the impact of this legislation that has passed on AI for their practices in California? What would that look like? And so, Aislinn, if you could move back to the slide related to the AI bills that have passed. For in particular, AB 3030, what does that mean for an individual practice?
I think it's to be determined at this point, Sylvia. We've got to keep a close eye, and particularly on how this will roll out, and the timeline around it. Again, this is a maturing market, but I think it's important to understand to be AI ready, you have to have all your governance in place. We need to make sure that our policies and procedures are updated. We also have to make sure that our data use agreements are updated, and that we're aligning all of that with our state and federal regulatory and requirements. And so one of the things that we are thinking about at OCHIN is how do we support our membership, and we are going to be providing a toolkit for our members on how to approach this, and making sure that there's AI responsibility as they are ready, as we're having readiness levels and moving out on AI. Because you don't want to have to roll out some AI tools that you have to go back and reconfigure with transparency disclosure or other sorts of adjustments on the back end. So ensuring you're AI ready is absolutely critical, making sure you have all your policies and procedures and governance and data use agreements and cybersecurity and all of that in place, even before you are considering and deploying AI, since it is a different type of beast, as we know. I wanted to also answer. I saw a question in the chat around the federal telehealth extensions. As of today, what we are hearing is that if they pass an end of the year package, there will be really a 2-year extension to the most of the flexibilities. But again, this is touch and go. It is election dependent. There's a lot of moving parts, but there is strong bipartisan support to extend the flexibilities. It continues to be a discussion about how do they pay for these things, the new modalities, because remember, many times you're not paying for care, you're going from zero care to telehealth, and that actually is budget positive for the federal government. So, we will continue to watch this and provide updates to you as well.
Great. And Jen, with regard to the second AI bill, we've heard examples where there is the war of the AI and prior authorization that because some insurers have been using AI to deny prior auth requests, clinicians are now using their own AIs, ChatGPTs, and others to develop their prior authorization requests. What are your thoughts on how this state-specific bill will impact that sort of war of the AIs in the prior authorization setting?
Well, I think the goal is to prevent the escalation, right? That was the whole goal of this legislation is, does my AI eat your AI, and does it climb the mountain of escalation? So again, we shall see. Again, it all depends on how the regulators look at this, and how they actually manage through this new legislation. But we are hoping that it will take the temperature down on the escalation wars between my chatbot and your chatbot. So that's all I can say on that, Sylvia, is we shall see. Hopeful, but we shall see.
And then one last question. California has clearly been incredibly active and at the forefront of state-based legislation. You, in addition to spending a lot of time in California and meeting with legislators and government administration officials, Newsom administration officials, you spend a lot of time at the national level. So what does that environment look like from your bird's eye view?
Yeah, I think I mentioned it earlier. There's still a lot of questions on how this will be formed. The Office of the National Coordinator, now the Assistant Secretary of Technology Policy, has officially created the Office of AI to help coordinate across HHS agencies and across the federal government. A lot of this still sits in what happens during the next month, and the election outcomes. Will determine whether it is something that has more patient focus, or whether it's potentially more vendor friendly. A lot will depend on the outcomes of the elections. There is general concern around artificial intelligence by members of Congress, and the desire to want to regulate the market is definitely there. I think it is reflective in a way that we're seeing in the California Assembly, but a lot of it is still, again, up in flux. And while the federal government doesn't seem to be moving at a rapid pace, the states are going to move faster. The concern that we have at Ocean is that we have a 50-state fragmented regulatory environment around AI. And unfortunately, those that have the most amount of resources are going to be the ones benefiting from that environment. So really, innovation in AI is tied into being able to try in different markets. So we're watching the macroeconomic issues impacting AI right now. What does it mean and how states are taking action? Because it'll be really difficult to navigate a multi-state environment as we are seeing in the privacy environment right now as well, this fragmentation from state to state. And it's very challenging in the digital world, as you know.
And then Jen, I know that you were involved in a number of conversations, and I want to call out SB 942, and this is the California AI Transparency Act. And this was one where there was lots of conversations back and forth with the sponsor of this bill related to whether or not these transparency requirements about the data sets used to develop content, or rather, I'm sorry, it's 2013. This one's the Training Data Transparency Bill. This was the conversations about whether or not that would apply to um, a whole host of algorithms that are used in healthcare. And can you share a little bit about what the sponsors thought were with regard to the scope? I know a lot of healthcare providers weighed in with some concerns about the reach of it.
Yeah, I think, with the big concern that we were seeing around that is what is the responsibility of the provider and what is the responsibility of the developer. And sometimes they're the same and many times they are not. And in the rural and underserved communities that we support, we want to make sure that our members have access to best-in-class technology and novel solutions to be able to improve provider burden or improve efficiencies or really simplify processes so we're delivering more patient care. I mean, because that's what this is all about, right? Is making sure the patient is at the center. Um, the concern on some of these bills that the healthcare provider community definitely has is where's the vendor producer responsibility? And does all of it need to lie on the provider? So this is the delicate dance between the regulatory environment as the provider is on the front lines. They may or may not know, especially if they are under-resourced or understaffed, all of the intricacies around AI tools. And so being able to have a thoughtful and balanced regulatory environment where there's responsibility on all parties, not just on the provider, is something that will consistently be a dance that happens in terms of this marketplace.
Right. Jennifer, I want to really thank you for your time and your expertise, and we look forward to having you back in the very near future in order to provide us an update on those AI conversations as they unfold. It's so important for all of us to be apprised of what's happening. Everyone here, we're all grass tops, and it's going to be iterative. So please come along for the ride with us. And also, Jennifer's doing a lot of work in the cybersecurity space. And so there's a tremendous amount we'd like to report out in that arena. And so we look forward to having you back, Jennifer. Thank you so much.
Thank you, Sylvia. Thank you, Aislinn, and thank you to the CTRC partners and sponsors. We really value you. Take care.
You. Now we're going to turn to our payment and regulatory updates and move to the next slide. Um, I would like to highlight a resource and a tool that we just rolled out as the CTRC. It's really quite remarkable. We scanned the horizon to find a tool for individuals who are new to digital health or even folks who've been around for a really long time, like our friend Maria, who's rolling out and implementing a lot of digital health tools. And this is a guide, and it's not like any guide you've seen before. It is interactive. It's available on our website. You'll receive this in our follow-up email for the folks that have joined us. And it basically lays out the key questions you need to be asking to determine whether or not there's a sustainable approach to digital adoption for your particular provider type based on the coverage of the patients that you primarily serve. So we have broken this up into several categories. So a lot of times you'll hear updates at the national level that really focus on Medicare and the physician fee schedule. We are focusing and creating an easy guide that allows you to look not just at Medicare, but look at Medi-Cal, look at different types of payers and how they're paid, whether it's on the physician fee schedule or if you're paid as an FQHC or an RHC, if you're paid as a critical access hospital. And then we're rolling out additional provider types as we go. And we're likely going to be providing both support and looking for partnership with our counterparts who support hospitals more broadly in the state to really create a robust guide that's freely available and regularly updated. So now I'm going to move into some Medicare updates. Now, we normally have this update during the late November, December period of time, and we are doing an early preview of what will be, again, our late November, early December update when CMS issues their final Medicare payment regulations for the upcoming year, which starts January 1, 2025. So we're going to go to the next slide. So during this session, Maria, you hit it right on the head. What is happening with regard to the PHE flexibilities in the context of telehealth? So I just want to underscore really quickly, we're talking about telehealth and we're not talking about remote physiological monitoring with regard to these flexibilities or e-consults. We're covering those topics today, but we want to just make sure that everybody is aligned, that we're not Medi-Cal and flexibilities that Medi-Cal has. We're talking about Medicare flexibilities in the context of telehealth, which mean interactive two-way video or audio only. So currently, as it stands, CMS has proposed that they will extend those flexibilities for FQHCs and RHCs through the end of next year. However, they have indicated they do not have the authority to do this on the physician fee schedule or for critical access hospitals. So those will expire on December 31st, 2024. Unless, as Jennifer noted, Congress acts. And as we are all very carefully monitoring when Congress comes back during what's called the lame duck session, there's a number of legislative packages that need to pass. And so we are hopeful that these extensions will extend for another 2 years. And as soon as we know, and as soon as there's action, we will be sending out immediate alerts to advise you. Now, there will be some trickiness because CMS likely will have to issue what's called an interim final with comment. And our anticipation is that it would be effective, we hope, on January 1, but it assumes that Congress will act before January 1. There also is a possibility that Congress does not act in time, and if they don't, there still remains the possibility the new Congress, which comes in mid-January, could act, and CMS could make those flexibilities applicable both retroactively and forward for 2 years. So Maria, please let me know if that answers your question that you had, and please keep them coming. Let's see, does anyone know whether hospitals that have rural health clinics can use the PHE rules? Yes. So that is an excellent question. I think your question above is a little more nuanced, and that's one that we probably should follow up on as well, because it applies to the rural health clinic, the question of whether it extends to the hospital that has an RHC. It will be depending on whether probably it's the originating site or if it is the distant site. So with that, let's move to our next slide. So we are going to focus on the physician fee schedule. This is separate and apart from focusing on RPMs or on hospitals. Okay, so let's let's make sure that we're all aligned that that's what we're focused on. So we touched on this, that Congress would need to act in order for the flexibilities that currently are in place would be extended. And I just want to remind you that those flexibilities cover several different aspects of what you're currently doing if you're operating under the physician fee schedule. And could folks in the chat let us know if you are reimbursed under the physician fee schedule, you're a rural health clinic, or you're an FQHC, or you're hospital based, and what kind of hospital? That'd be really helpful if you're a provider. So just really quick recap, these flexibilities extend to where the patient is located. So pre-pandemic, they had to be in a rural area, the patient did. It applies to the location of the facility. So whether or not the patient not only was in a rural area, but they had to be in an originating site like a clinic, as opposed to their home. And, with the pandemic, the requirements for facility type were completely waived. And so patients could receive their care in home. And there's only a very limited number of scenarios in which a patient can receive their care in home, even if they're located in a rural area. The pandemic also resulted in flexibilities, expanding the types of practitioners who could provide telehealth services, like physical therapists. So those were expansions that without these flexibilities would go away. And we just want to underscore, because there's so many folks who conflate telehealth with other digital modalities like RPM, RTMs, e-visits. I want to underscore e-visits, for example, these don't go away, but they have to be for established patients. So even if you're on the physician fee schedule, it looks a lot like a telehealth visit, but it's not considered a telehealth visit, but it is limited to established patients. If you have questions, let us know in the chat. So we're going to move to the next slide. So despite this rather, concerning turn of events unless Congress acts, there are flexibilities that will be extended by CMS for those services that are permitted. So, for example, there is going to be a permanent extension of audio only for patients. And this is really important. And the reason why it's important is because there was a move afoot to really dramatically limit, from some certain stakeholders, audio only telehealth services. And there were new codes created for audio only services. CMS did not adopt those codes in their proposed rule. We don't expect to see them in the final rule. And as you'll note on all of these slides, except for the DEA slide that we'll talk about, these are all proposed, and we'll come back in November or early December with the final rules. But this is to help you get ready for what we think the changes are, and to start doing some contingency planning so you're not scrambling to do it at the end of the year. Also, great news is that CMS is proposing to extend again the listing of the address for practitioners. That would be based on their practice location instead of their home, even if they're delivering a virtual service from their home. And this is also great news. There were, personal security concerns and safety concerns with the obligation for them to list their home address if that's where the services were being delivered. CMS also has expanded and plans to expand, rather, flexibilities with regard to virtual direct supervision. This would expand the scenarios in which you would be permitted to provide that direct supervision, which, as we all know, direct supervision is much more stringent than general supervision. But CMS is lifting some of the challenges associated with direct supervision, where you have to be co-located in the same place at the same time with the supervising clinician. When you have a clinician who's under their supervision and is providing services incident to, So this is great news. And also frequency limitations have also been lifted with regard to inpatient and nursing facility visits, which is also quite welcome. So these two are rather these the summary of these are great examples of how CMS is trying to exercise all the discretion that it does have to the greatest extent it can to ensure the adoption and use of digital health services. So we're going to move to the next slide. So having said that, we do switching gears from telehealth, so two-way interactive video or audio only between a clinician and a patient. We're now going to switch gears to what is essentially a form of remote therapeutic monitoring. And if you folks could share with me is if anybody is currently implementing remote therapeutic monitoring in their practices, it can be quite complicated. And CMS, in order to address the mental health, public health crisis that we're all facing, where there's a real lack of staff available to deliver these services. We are now seeing CMS exercising a whole host of creative solutions. Having said that, this particular proposal that CMS is now offering is to cover what is essential remote therapeutic monitoring for digital mental health services. And so these have proven to be quite effective in creating additional capacity and scale. However, these are not without controversy. One, because they look a lot like remote therapeutic monitoring codes and services, which have their own codes that are widely available. So these would be new codes that we would have to add. These are what are called HCPCS Level 2 codes. And so they are not as easy to bill with other payers who may or may not accept this coding convention. And also the differentiation between the services can lead to some confusion. However, I think the intention behind this is very helpful and it underscores the benefit of evaluating whether additional tools can be used to scale capacity within your clinic, within your facility in order to provide effective digital mental health augmentative services to support a treatment plan that you're implementing for a patient. And we do have resources about the evidence base around this and to support it. So we're going to go to the next slide. So what we're seeing is, however, we don't know that CMS is going to finalize these particular codes because a tremendous number of stakeholders have asked them instead to simplify the codes, streamline it, let providers use remote therapeutic management codes in order to bill for these services and then just simply pay for some of the codes under remote therapeutic monitoring that they currently do not. Specifically, CMS is not paying for the supply of medical devices in the context of the RTM codes. So if you would like to learn more about this and would like an in-depth session on remote therapeutic monitoring, both the evidence base and the payment, please let us know in the chat or let us know at CalTRC at ochin.org, and that will be very helpful. So we are waiting to see what the outcome will be, and as soon as we know, you will be provided in-depth information on this. So I'm going to have Aislinn please move us to the next slide. Okay. CMS also is really focused on providing additional tools to providers who are moving to alternative payment models and trying to create additional flexibilities and incentives in order to use digital health modalities. So right here, you have a great example of advanced primary care management services, which include in a bucket a whole array of digital health modalities that CMS is going to pay in a per member per month scenario. However, you have to be in one of the existing APM programs like the Medicare Shared Savings Program in order to utilize these codes. And so, as you can see, Jan Aledo has listed out the particular plans that these apply to. So you'll see there that there's a fair number that are included. So you should evaluate whether or not, if you're in an alternative payment model, you would be eligible for these services. We do anticipate that these likely will be finalized, perhaps with some tweaking, and we will alert you once we find out. So moving to the next slide. Again, in the vein of CMS really being focused on some priority areas like addressing the mental health crisis, addressing the need to create incentives to move to new alternative payment models, and in this case, addressing another public health crisis around opioid treatments. And so this particular proposal, again, we fully anticipate CMS will finalize. And essentially, this allows assessments for opioid treatment to be done via audio only, and this would extend out much further than had previously been anticipated, and it is contingent on the next update, which I'll be talking about, and that's with regard to the DEA's flexibility on the use of telehealth. And so want to underscore this and wanted to see how many of you are offering opioid treatment programs. And again, if you're interested in learning more, please let us know, and we can provide some more in-depth content and resources for you. So we're going to switch gears and move away from the physician fee schedule to FQHCs and rural health clinics. Next slide. And in a nutshell, CMS really brought the holidays home early by proposing to extend the telehealth flexibilities through the end of next year. Now, in addition to Congress potentially acting on the physician fee schedule and extending those flexibilities 2 years, we anticipate that if Congress does act, they not only will extend that 2 years for providers on the physician fee schedule, but they'll also do it for FQHCs and RHCs. But it does look like CMS has created a safe harbor for FQHCs until the end of next year. They also have extended additional flexibilities with regard to direct supervision, which I talked about previously on the physician fee schedule. That applies for FQHCs and RHCs as well. And they also have proposed to delay the in-person visit requirement for mental health telehealth visits similarly until January of not 2025, but 2026. So moving to RTMs and RPMs, just really curious how many of you are FQHCs or RHCs that are already deploying RTM and RPMs. We would really love to have a conversation with you and about some of the challenges and opportunities that you've been facing, including the difference between coverage by Medi-Cal versus coverage by Medicare. We'll note that Medicare, for the first time ever this year, starting January 1, 2024, was covering both RPM and RTM for FQHCs. And this is quite significant. And they created a general code, G0511, and this general code is now being proposed to be sunsetted, and instead for you to use the existing CPT codes that are typically used on the physician fee schedule. And one of the benefits of that approach is that you can also use the codes that do add-ons for more intensive services. However, there is some concern that the new rate may not be adequate to cover costs. And so we're going to continue to monitor that and provide a clear update. But in the interim, please reach out to us, send us an email, reach out to us in chat. We'd love to learn more about your practice and what you need. Okay, so Very quickly, because we are close to the end of our time, we are going to move to the next slide. We're going to move to the next slide, Aislinn. So, pre-pandemic, it had been the case that DEA required you to first have an in-person visit with the patient before you could prescribe a controlled substance. Um, During the pandemic, they said you could prescribe using interactive video. Even if you've not had an in-person visit, we're going to waive our requirements. And if it's for substance use disorder, opioid use disorder, and you're prescribing buprenorphine, you can even use audio only. Those flexibilities are about set to sunset. However, it now looks like the DEA is going to extend those flexibilities. We don't know if it's going to be 6 months or a year. We just know that right now it's sitting on a regulatory docket. We can't see the content. We just know it's waiting to be released. As soon as it is, we will alert you. And again, we're very interested in knowing how many of you will be impacted if this DEA flexibility goes away. If you could email us, message us, we would really love to know. So, Marie, if CMS does extend deadline and it appears they will not adopt the new audio only and audio video codes, does that mean they will continue to use modified E&M codes? So, Marie, if they not the new audio and audio video codes. Does that mean they will? So yeah, I think Marie, they're going to continue to use the modified E&M codes. They're not going to adopt the audio only codes. So what you would end up doing, and folks, this is for Medicare telehealth coverage on the physician fee schedule. You currently use the code you would use if you were providing the service in person, and then you add a modifier to designate whether it's interactive video or audio only. That will continue. So there had been some stakeholders who said we should create entirely new codes for audio only. And they should look different than the in-person codes that are modified by the interactive video. So that latter proposal is dead. It's not even in the proposed rules. So if CMS does get the flexibilities moving forward, they will just extend their current practice, which is use existing codes with modifiers. And I hope that answers your question. So that brings us to the end. We're going to quickly move to the next slide. And I would like to thank again Jennifer for her presentation and just remind you all that we do have resources on healthcare AI. We have a toolkit. Strongly encourage you to take a look at it. We're also offering a 3-part boot camp, 2 sessions that are virtual, 1 in person. We'll be sharing more information about that soon. And then, Aislinn, if you could move to the next slide, just really quickly. We are also having another session about telehealth in schools and libraries and implementation. This is a great how-to change management operational implementation. Encourage you to log in or share with folks who are interested. And then stay connected with us and follow us. You can take a scan me shot here, and we would like to thank you. Your time is valuable. We know that you're really busy. And we'd also love to hear from you if you would prefer 30-minute webinars as opposed to hour webinars. We know you're really busy, and we want to bring impact and value to you that you can use every day. And we appreciate being one of your partners on this journey of digital adoption. And have a great day. Thank you.